Good afternoon, everyone, and welcome to SAMHSA's Gain Center. Today, we are excited to present a webinar on the role of the criminal justice system in reducing the duration of untreated psychosis. And we are really excited about the presenters we have with us today. I am Melissa Neal. I'm a Senior Research Associate with Policy Research Associates, and I'm the lead for communications coming out of the Gain Center. And I just have a couple of housekeeping items to cover with you. So first, the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. You will see on the right side of your screen, the right lower side of your screen, there is a Q&A portal. And throughout the presentations, you are welcome to submit questions. And at the conclusion of both presentations, we will address as many questions as possible. We also have a couple of polls that have just popped up on the right side of the screen, and we welcome you to participate. This just allows us to see who all's joining us today, where you might be in terms of rural or suburban or urban locations, as well as what types of agencies or organizations you're representing. So we welcome your participation in those polls. This webinar is being recorded, and we will be disseminating slides as well as a webinar recording in the days after this webinar. The actual slides are disseminated within a matter of days through our Gains listserv, so please make sure to sign up for that. And then once the full recording is posted to the SAMHSA YouTube channel, we will disseminate that link as well. Many of you ask about a certificate of attendance, and that will be available for download at the end of the webinar. So we have a full agenda today. We are really excited to have Dr. David Shern here to provide some opening remarks. And then we have two presenters, Dr. Pollard and Dr. Pope, who are going to be presenting more specifically about this topic. So for now, I'll turn it over to Dr. Shern for his opening remarks. Dr. Shern?
Hey, thanks, Melissa. Thanks, everyone, for joining us, and special thanks to the Gain Center for sponsoring this webinar. The last several years, about the last 5 years, the organization I work for, the National Association of State Mental Health Program Directors, which is a professional association that represents all of the mental health commissioners throughout the United States and in the territories, has been involved in developing technical assistance materials to help with the implementation of a new national program that SAMHSA has sponsored with new block grant monies, and those funds have been targeted for the development of first episode programs based on a coordinated specialty care model that represents a strong evidence-based approach to reaching and serving people with first episode psychosis. The notion being that the sooner we can get to people who have experienced a psychotic disorder and get them the kind of wraparound and support services that are necessary to keep them sort of on their life course and to work with them around controlling their psychosis and continuing in school or in work and in their interpersonal relationships and are working with their family. The sooner we can do that, the better off they ultimately will be, with the hope being that eventually we can really stem the tide of disability. Now, in order for this to work, it's really important that these specialized services, which are now available throughout the United States, there's certainly not an adequate number to serve the entire population, but there's some 300 programs located throughout the United States, that it's important that people be connected with effective care as quickly as they can. And in order to do that, it's important that these CSC programs have connections with the various networks in their communities who are likely to come into contact with individuals who are in a mental health crisis, and specifically with individuals who are exhibiting symptoms of a psychotic disorder. So therefore, as part of our technical assistance portfolio that we've developed, we have materials available for information around contacting schools, working with primary care providers, et cetera, working with the faith community. And we've been really fortunate to have worked with Leah Pope and Jessica Pollard to develop a document about how to effectively work with the criminal justice system in shortening this duration of untreated psychosis and in increasing the likelihood that people will be able to get back into their life and live a long and productive life, even though they have, a serious mental health condition. So the GAIN Center is helping us today to reach out specifically to a law enforcement audience, which is a primary constituency of the GAIN Center. And so, again, we really thank them for that. So as Melissa said, we're really lucky to have two excellent presenters today. And the first person I'm going to introduce is Dr. Jessica Pollard. I've been lucky to work with Jessica in a couple different venues over the last several years. She's an assistant professor in the Department of Psychiatry at Yale and works in their STEP program, which is an early intervention, one of the first early intervention programs actually in the area. And Jessica's been very helpful for us in a couple of different venues. One is she, along with Michael Hoagie, has developed a technical assistance product that's focused on workforce issues. As you might imagine, workforce issues are important in this new specialized program. And additionally, she and Michael prepared for us a technical assistance document around transition from care, which is tricky. The notion of step-down services is kind of where the field is at now with regard to what we do for persons who've completed a coordinated specialty care program. I've also been fortunate to work with Jessica at the American Public Health Association, where she's the chair-elect of the section, and she's taken on the Herculean task of preparing our program for the last couple of years, which is a really arduous task. So it's great that Jessica's joined us. And Jessica's going to be joined by another person who's really been enormously helpful to the field in general, and certainly to NASHBID and our sister agency, the NASHBID Research Institute, and that's Dr. Leah Pope. Leah is an anthropologist by training, and she has really specialized in the issues of the interface of the criminal justice system in people with mental health conditions. This is, as you all know, is a burgeoning field. The issues that get people involved with the community with the correctional system, and keeping them in the most appropriate setting is of critical importance. And Leah has been terrific as a resource for NASHBID, and she was a primary author of a technical assistance document specifically on this issue that will be featured at the end of the presentation. So with that being said, Leah, why don't you take it over?
Great. Hello, everyone, and thank you for joining us today. And thank you, Dave, for that great introduction. We are going to get right into the presentation so that we can leave time for questions this afternoon. So I will not spend a lot of time on introductions since David already did that. As he said, I'm from the Vera Institute of Justice, and Dr. Pollard is from Yale, working as the clinical director at the STEP program. And Jessica and I have been collaborating for the last couple of years, given our joint interest in this issue of how mental health service providers and criminal justice stakeholders can collaborate specifically around the needs of young people experiencing a first episode of psychosis. So an outline of what we're going to cover today, we'll start by really defining the problem, talking about the scope of mental illness in the criminal justice system, as well as psychosis and psychotic disorders in particular. We'll define psychosis and its symptoms for people who are unfamiliar. And we'll talk about why this matters to both criminal justice and mental health providers. We'll then go a little bit into thinking about the criminal justice continuum, how people move through the system, and what the different roles of criminal justice professionals can be in both interacting with people with psychosis as well as interacting with mental health service providers. We'll then move on to really thinking about what justice involvement looks like for clients with first episode psychosis and how we can support them, as well as build relationships across these different categories of stakeholders. And then we'll leave time for Q&A for people. So just to start, I have a slide up here that gives an overview from the Prison Policy Initiative about our incarcerated population in the United States. And I like to start with this really just to provide some context for the big picture here. As this graphic shows, there are over 2.3 million people who are incarcerated in the United States, in both state prisons as well as around 3,000 local jails across the country. So huge numbers of people who are in our nation's jails and prisons on any given day. I think the other thing to focus on is what this graphic leaves out, and I'll highlight two things. One is that you can't tell from this graph that there is enormous churn in the system. So although there are 2.3 million people who are incarcerated in the United States, there are about 12 million jail admissions each year. And it's important to remember that in jail, most people are pre-trial, so that means that the majority of people being held in jail have not been convicted of a crime yet, and they have very short lengths of stay often. The vast majority of people are staying only a few days, under a month. And so I highlight this to really suggest that people are moving in and out of the system. Many of these people have mental illnesses, as we'll get to in a minute, but there's a lot of turnover. The second thing that this graphic does not highlight that is worth mentioning because it's relevant to our conversation here today is the high number of people in the country who are under correctional supervision. So there are about 4.5 million additional people in the United States who are under the supervision of probation and parole. And of course, millions more, about over 10 million people who are arrested every year. And these are important numbers to note too, because it suggests that there are these other stakeholders, police officers, probation and parole officers, who we should be thinking about in terms of building collaborative relationships when people have psychosis. Obviously, a high likelihood that young people in particular are going to be arrested in the United States, given the numbers and the likelihood of young people experiencing arrest. We move on to focus a little more narrowly on mental health or mental illnesses in the criminal justice system. There's a large evidence base now that establishes that people with mental illnesses are overrepresented in the criminal justice system at all stages. The prevalence estimates really vary depending on the methodology, but in all cases, the studies show that the rates of mental illnesses are higher in jails and prison than in the community, and mostly higher in jail than in prison. So up here, you'll see the latest data from the Bureau of Justice Statistics. In that publication that was just published less than 2 years ago, they used the K6 scale, the Kessler scale, for serious psychological distress. And you can see here that over a quarter of people being held in jail met the criteria for serious psychological distress. And that's a measure that asks people about symptoms in the 30 days prior to arriving in jail. And then an even higher number, almost half of people in jail and over a third of people in prison indicated that they had been told by a mental health professional that they had a mental health disorder. So really high rates of people coming into the system and indicating that they either currently have symptoms or have been told by a mental health professional in the past that they actually had a mental health disorder. This next slide that I'm showing is just a different way of looking at some of the same information, and it's really showing the comparison between the rates of people in jail who experience serious psychological distress, who meet that threshold. Again, you can kind of see that over a quarter of people, and comparing those to those who are arrested, those who are under supervision, and then people with no criminal justice involvement, and then, of course, the general adult population. So you really see it's 5 times higher for people in jail than in the adult general population based on the latest available data. Now, of course, when we're talking about first episode psychosis, we're talking about an even narrow category of illness, psychotic illnesses. And here too, the data is, there's been less focus on this in the data, on specifically looking at psychotic disorders, but the data that does exist shows that here too, it's higher than the community. So about 1 to 2% of the general population will experience psychosis in their lifetime, and that rate is about 2 times higher in correctional settings. That's in terms of diagnosis of a psychotic illness. But the chart here I show, I think, is even more telling, and that shows that high percentages, nearly a quarter of people in jail, report experiencing at least one psychotic symptom in the past year. So 1 out of 4 people in jail reporting that they're experiencing a psychotic symptom in that past year before getting to jail. And I think this is one of those key data points that really, we should focus in on in terms of thinking about how the chance of identifying someone who's experiencing psychosis is likely higher in the criminal justice system than it is in the community. It's an enriched population, if you will. And so that's really why we've thought about how the criminal justice system is really a critical intercept for identifying people with psychosis and connecting them to appropriate treatments. So having established that kind of background of what the data and the prevalence shows, I'm going to turn it over to Jessica to give a primer on psychosis for those who might not be as familiar with the illness.
Thanks, Leah. So thinking about psychosis, we're really referring to a broad category of disorders that have a biological basis but are heavily influenced by experiences and the person's environment. So things like substance use, stressors, traumas, all of those things can contribute to underlying biological vulnerabilities and result in a psychotic disorder. There are primary disorders like schizophrenia. Some mood disorders can present with psychosis, like depression, bipolar disorder. And there are a number of health conditions, physical health conditions, that can have psychosis as one component. For example, seizure disorders, people can experience psychosis as part of that presentation. And to count something as psychosis or a psychotic disorder, you have to have at least one of the 3 following symptoms that we refer to as positive symptoms, not because they're good, but because they're the addition of something that wasn't present prior to onset of illness. So that's difficulty with reality, with coherent thinking. The person may seem out of touch and not be aware that what they're experiencing is illness-based, and they may be very difficult to follow when they're speaking. Delusions are not just false beliefs, because we all have wrong ideas sometimes, but they persist even with evidence to the contrary. They're often unusual, but not always. And it's important to recognize these aren't just beliefs that we disagree with, but they're also outside of the person's own cultural belief system. Hallucinations are false perceptions that can occur across any sensory domain. So the person truly experiences something that isn't there. So taste, touch, smell, hearing something, the brain is responding, but there's no outside stimulus. And just a quick note that all of us can have some degree of these experiences, because sometimes when I give this presentation, people start to really worry. This is a continuum, just like most human experiences and characteristics. So all of us have a little bit of difficulty at times with coherent thinking, maybe early in the morning before we've had our coffee. And all of us have, many false beliefs, but hopefully we let go of them if someone shows us proof that what we were thinking was incorrect. And every once in a while we see things out of the corners of our eyes, or we think we hear our name in a crowd, or our cell phone buzzing when it isn't. And I say that as well because it's important to recognize psychosis is on a continuum, because we don't want people to wait until it's blatantly obvious that a person is suffering. We really want to catch these symptoms early. So it's important not to minimize, even if the symptoms are kind of on the lower end of the continuum. As Leah mentioned, the symptoms, the diagnosis or lifetime prevalence of psychosis is more common than most people probably realize. It's a lot more common than a lot of physical health conditions that we may be more familiar with, such as multiple sclerosis or diabetes. And that this is an illness that has a big impact not just on the people experiencing it, but also a huge economic burden, $60 billion a year in the U.S. It can be disabling, though it doesn't have to be. It's currently still among the 25 top leading causes of disability worldwide. And believe it or not, it can actually even be a matter of life and death. So people who have a diagnosis of schizophrenia are at much higher likelihood of dying early compared to their peers without psychosis. And this is especially true with first episode psychosis. And that rate is 24 times that of peers who do not have psychosis. And so for more information about that, there's a paper by Schoenbaum in 2017 that goes over where that data came from. And what does psychosis look like? So I gave you a bunch of symptoms, but if you're not a mental health provider and you are thinking, how would I actually know it when I see it? These would be some of the behaviors or observable things that you could look for. So almost everybody who's experiencing the onset of psychosis or a psychotic episode has some kind of change in their sleep, usually disruption to their sleep, less sleep, or a lot of interrupted sleep. So we might not necessarily notice that, but we might notice if the person is no longer eating, refusing food, or appearing suspicious of food. So the person can have appetite changes, but they can also become paranoid that their food is contaminated or poisoned in some way and stop eating or only eat things that are prepackaged. People who might have previously been outgoing become very isolated. Withdrawal from friends and family and anyone around you is pretty common during psychosis. We see a lot more changes in mood or mood lability, irritability, anxiety, depression are common. And then on the flip side, sometimes when we're interacting with somebody who's experiencing psychosis, they can appear completely flat, no emotion on their face, no expression of emotion, and that's a pretty common observable symptom as well. And we can also notice that people are appearing to respond to things that we aren't aware of or that we don't notice. So we call that in the clinical terms responding to internal stimuli, but you would notice that the person is maybe looking around as if they're seeing something or even verbally responding as if someone's speaking to them when no one is. This can also be internal preoccupation, so the person is so engrossed with what's going on in their head that they're not paying attention to what's going on in their environment. Along with the positive symptoms I mentioned, there are also cognitive symptoms, so they can look very similar to ADHD, poor concentration, distractibility, and negative symptoms where the person has fewer things or the taking away of things that they had prior to illness onset. So less energy, less emotional expression, as I mentioned. Self-care can decline, so the person's hygiene may suffer. And we can also notice if the person is talking to us about beliefs or ideas that don't make sense or they're irrational. And when you're interacting with someone who's rambling, going off track, their answers don't match your questions, all of those are potentially signs of psychosis that we really don't want to ignore. And I'll get into why that's so important in this next slide. So why do we think about this intersection between the criminal justice system and first episode psychosis? So there are a lot of reasons to think, and we have a lot of data to support this, that symptoms of psychosis can lead to criminal justice contact. So both because the person may be, or the people around them may be actively seeking emergency services, or because their behaviors can be concerning to others, and we'll talk about that in a bit more detail. This is also important because though as a whole, people with psychosis are more likely to be victims of violence than perpetrators of violence, and there's a lot of sort of overblown estimation of how violent a person with a psychotic disorder is likely to be, it is the case that if violence is going to occur in the course of a psychotic disorder, that it will happen early on compared to other phases of illness. And we have good documentation. There is a high degree or high likelihood the person will interact with the criminal justice system during first episode psychosis, and that we may be more likely to find individuals with first episode psychosis in the justice system than in the community, which is really important for this whole concept of early detection and finding people that we want to bring into care. That can be part of the pathway to care that for a significant number of young people in the early stages of psychosis, that contact with the justice system may be the first opportunity for somebody to intervene and get that person connected to specialty care or treatment for psychosis. We know that criminal justice involvement lengthens this incredibly important variable known as the duration of untreated psychosis. So DUP refers to the time from onset of full-blown symptoms to connection to appropriate psychiatric treatment. And that can be defined in a few different ways, but across DUP studies, it's one of the strongest predictors of outcomes. And, clearly the shorter the better, as Dave was referring to earlier, but we even have data from almost 20 years now of a DUP reduction study in Norway showing it can affect functional outcomes and quality of life even over a decade later. So it's an incredibly important variable. And unfortunately, as I mentioned, the history of criminal justice contact can lengthen duration of untreated psychosis, which intuitively makes sense. If somebody gets incarcerated, they're less likely to be connected to specialty care. But it's not just incarceration. There can be other ways that justice system involvement drives the person away from treatment. And so we know before people with first episode psychosis are psychiatrically hospitalized for the first time for a psychotic disorder, already almost a third of them have some history of criminal activity. Other samples show 70% have a history of arrest, and up to 60% have been incarcerated. And that is consistent with data that we found in STEP, which we presented preliminarily a few years ago at the American Public Health Association, and hopefully you'll be able to see it in press soon. We found about 14% of our sample had a conviction for any kind of crime prior to coming to us. These were predominantly, over the course of the whole study, nonviolent misdemeanor crimes. And the good news is, because these are some not so great statistics here in terms of greater symptom severity and higher likelihood of future criminal justice contact in general, what we found is in our randomized trial comparing STEP to usual treatment, that our patients in STEP were less likely to be convicted of any offense after they entered treatment, and they were sentenced to fewer total months in jail. And we had a pretty long follow-up period ranging from 5 to 11 years depending on when the person enrolled in our study. And our survival analysis showed that our STEP patients had a significantly longer length of time to first crime on their survival curve and a lower 5-year crime rate. So we're pretty happy with those outcomes, demonstrating that specialty care can make a difference even in criminal justice outcomes. And a little bit later, I'll talk about some of the other outcomes that we've seen for this kind of specialty care. But for now, Leah's going to give us more of an overview of those pathways in the criminal justice system.
Thanks, Jessica. So I am going to review next a model that has become widely used in the criminal justice space called the Sequential intercept model. This was developed about 15 years ago, and Policy Research Associates has done a really wonderful job of transforming it into a linear model to help communities think about the interaction between the criminal justice system and mental health system. If you are a criminal justice stakeholder on the phone, this is obviously not new to you. You probably understand how people move through the system, but our hope is to really highlight opportunities for off-ramps. And if you work on the mental health services side, this should be a good primer to think about who are the key contacts that I can think about when I'm getting people who might have criminal justice involvement, and what can I expect that person's experience to be like moving through the system. So the framework of the sequential intercept model is really, it starts with the idea that people with mental illnesses should not penetrate the criminal justice system at greater frequency than anyone else. And so starting with Intercept 0, which was added in the last 2 years, we're really thinking about what are the community services that need to be in place in any community to really prevent justice involvement in the first place for people with mental illnesses. Those can be things like crisis lines, the kind of the behavioral health safety net, as well as communities are now developing crisis centers, for example, that people can walk into if they're experiencing a mental health crisis. Then once people kind of move along the map, they get into more formal criminal justice involvement. In Intercept 1, that really means police involvement. We know both from tons of anecdotes, but an increasing amount of data and exposure in the field that law enforcement officers are frequently first responders to people with mental illness. But we also know that across the country, jurisdictions are developing police mental health collaborations in order to really build those connections between the mental health service system and the criminal justice system at the earliest stages. And so in some places that looks like crisis intervention team training, where you have a specialized team of law enforcement who are trained in crisis intervention team training and can be dispatched to people in crisis. It might look like a co-responder team, which is, there are multiple models across the country, but it often involves a police officer, especially trained police officer, who's riding along with a clinician. So that, in and of itself, those sorts of responses can lead to alternatives for a person who's experiencing an episode of psychosis, rather than further involvement in the justice system, such as through an arrest. I won't go through all of these stages, but you can see how people move through the system, then to their initial court hearing. Here too, there are opportunities to connect people to services. And really the most important thing to note is people move through and almost everyone is returning to the community, whether that be immediately or through a period of incarceration and then parole, which may include mandated treatment. But I think it's important to remember as we think about these that even people who are going to jail or prison are coming home and will need connections to care. This next slide I put up just as it kind of blows up the sequential intercept model into a much more detailed mapping of how people move through the system. And I put this up here only to highlight that, of course, the criminal justice system is very complex. There are multiple pathways that any individual case can take, which makes things complicated. But I like to think that this also is a way to highlight the multiple opportunities we have to kind of prevent people from moving further and further into the justice system, and to think about what are the different roles different stakeholders can play to ensure that involvement is as minimal as possible. As I move along to the next slide, I highlight here just some of the key stakeholders that you may interact with if you are a mental health provider. Of course, police at the first onset. And then sometimes mental health service providers are less familiar with people later on in the system, particularly people who might be key stakeholders at that Intercept 2, which is where people are first being arraigned or having bail set, having their initial court hearings and potentially going to jail or being held in jail while those initial court hearings are happening. And these are really key people that clinicians can be knowledgeable about and even reach out to if their clients are justice involved. Pretrial services and bail commissioners often serve similar tasks in terms of interviewing people at an early stage prior to their trial and determining their ties to their community, the likelihood that they'll reappear in court, their risk level, things like that. And they often make recommendations about release. So those are times when connections to existing mental health service provision can be really important for thinking about ways to keep people out of jail during the course of their trial and connect them back to services. I highlight on the next slide a number of models that exist along this continuum, just to give people a sense of other opportunities that there are in their community or could be developed in their community to keep people with mental illnesses out of the justice system. So if you start at intercept 1, law enforcement assisted diversion is an increasingly popular model across the country. This is something that most places call pre-booking diversion. Again, it kind of looks different depending on the specific location, but the driving force is that police officers have discretion to arrest a person depending often on a certain number of charges. And so the idea is to really keep people with mental illnesses, or often in the case of lead substance use issues, out of the justice system by giving that officer more discretion to not make an arrest and to connect people with services that they might need, such as substance use services or housing services. It's really a harm reduction approach. Moving along in the system around intercept 2, you get what are called post-booking diversion options. And these could happen either pre-arraignment, before someone's arraigned in the courtroom, or more commonly post-arraignment, after that person has their initial court hearing. Most of these, are going to include some type of monitoring, screening, and eligibility to make sure the person is appropriate for the program. And I think it's really key to recognize here that entry into these programs is often the result of negotiation among a number of stakeholders, such as prosecutors and defenders and judges and potentially mental health providers. And that these negotiations and entry into these programs can take time, and often that time that they're waiting for their case to be transferred or to make a decision is time spent in jail. So even people who get diverted often are going to be spending some time in jail, and even that minimal amount of time can have negative impacts on their mental health. Of course, there are also probation programs that could happen with or without jail time. There are alternatives to incarceration, such as community service. And then, of course, someone could be incarcerated, in which case they wouldn't have the opportunity to be diverted, but there could potentially be options for treatment inside jail. I also, we've put up here just a side box to mention competency restoration and not guilty by reason of insanity. And we mention that because these might be other ways that clinicians may be called on to interact with the criminal justice system or with stakeholders in particular. We often get asked about those roles, and those are other areas where you might see clinicians interacting in the system. So I'm going to turn it over back to Jessica in a minute, but I'll just end off this section by talking about how we're going to transition into thinking about how might first episode psychosis in particular lead to justice involvement. And I think at the outset, often we see that what's prompting justice involvement is actually emergency help seeking. So individuals, or many times their family members, may be calling 911 because they're seeking help, and that brings in law enforcement. Or they may be engaging in behaviors that are considered criminal and thus interact with police as a result of that and are possibly charged with a crime. And so oftentimes, as I turn it over to Jessica, we're thinking about what are the specific clinical reasons that someone with a first episode of psychosis might actually get involved in the justice system. With that, I'll turn it over.
So as Leah mentioned, we think about clinical presentations as potentially reasons why people might get noticed by the police or even charged or incarcerated based on their symptoms that manifest as behaviors. So these are examples in red are actually from our sample in the STEP program. So the study I mentioned, we have these examples of charges that people were convicted of as a result of, or at least in the context of their first psychotic episode. So as I described the symptoms of psychosis before, sometimes people's behavior is bizarre and can therefore be frightening to other people. So perhaps they are speaking loudly on a street corner, or they are behaving in ways that don't make sense. Maybe their movements or their ways that they're interacting with people in public could be very strange and unusual. They might be yelling, and that can result in things like breach of peace or disturbing the peace or disorderly conduct. So as a particular example, a young man that we've worked with has sometimes when he's gotten delusional started accosting people on the street, yelling at them in a way that felt threatening to passersby based on the delusions he was having that he needed to give people particular knowledge, or he needed to warn people about some impending danger that he believed was coming. And it's also very common that the young people in our programs are using substances, so that can result in possession or intoxication charges. And the disorganized behavior that we see in psychosis can lead to things like wandering into private property, even going into somebody else's house or backyard. And so those can sometimes result in trespassing charges or even larceny if the person removes things from somebody else's property. Paranoia and the belief that you're being persecuted, that can manifest in a variety of different ways that come to the attention of the justice system. So making a false police report if the person calls to report a crime or what they believe was a crime that didn't actually happen. A young man we worked with called in a belief that he thought there was a bomb in a particular place, and he truly believed this, but turned out not to be true. And so thankfully he wasn't charged, but other people we've worked with have been charged with making false reports. Or harassment. It's not uncommon for people to be paranoid and thinking that their neighbors or people in their family or people around them are out to get them, and if they're confronting that person, that can be really upsetting to the person who's a target of that delusional belief. And people sometimes when they're hearing voices will look for an explanation of where it's coming from. So my neighbors must be doing this to me, and that can result in some altercations or some charges around those interactions. Agitation, so sometimes the police or 911 is called because the person needs help and the family is concerned, but when the police show up and there's an interaction around going to the hospital, the person may not want to go to the hospital, and that can result in sometimes charges like resisting arrest or even assault charges if there's altercations with the police. The agitation itself can result in behaviors that are concerning to other people, result in threatening or even property damage if the person's punching walls or throwing things. Grandiose delusions and other kinds of delusions, so grandiosity, the sense that you have special powers or you might be a very important person, that we've sometimes seen result in a person believing that they had a relationship with somebody that they didn't have, and that can lead to protection orders and violation of protection orders or even stalking behaviors. The person really believes they have a relationship with somebody even though there's no evidence of that. Or grandiosity, everything belongs to me, or I have some kind of special status that means I can take things and go where I want. And then as I alluded to, when people are delusional, they can become angry and upset about those beliefs, and that can sometimes even result in physical altercations. So if you think somebody's poisoning you or out to get you or doing these bad things to you, that might actually result in you having a physical fight with them or pushing or shoving them, and that can result in those kinds of charges listed. And associated mania, so that we've seen result in things like engaging police in a pursuit, speeding at high speeds down the highway, refusing to pull over, Sometimes people will remove their clothing and get charged with public indecency. We've seen that actually a number of times, nudity in the context of mania and then being in public, or reckless endangerment. If you have somebody with you. So a young man we worked with who thought he was sort of rescuing an elderly family member from the nursing home, taking her for kind of a fun, what he thought would be a fun day of outing. That resulted in some charges because his judgment wasn't there, and he took her without permission and caused everyone to be concerned about her whereabouts. And then, so those are all the things that can happen. Not all of the things, I should say. My little asterisk on the previous slide was saying not an exhaustive list. Those are just a few examples. And so switching over to early intervention and why we should be focused on thinking about criminal justice stakeholders really helping those of us on the mental health side, making sure people get identified as in need of treatment, is because we know that early intervention can be really effective. So by now we've had multiple large randomized controlled trials on this early intervention model that in the U.S. is known as coordinated specialty care. Early studies were in Europe, and then we've had now at least 2 in the U.S., STEP being the first, and then a large national study called RAISE. And it's important to note that the superior outcomes of these kinds of specialty programs are not just about symptoms. They're also about things that are important to patients and families. So being more likely to be working or in school, independent living, having a higher quality of life, those are also superior outcomes, or ones that are significantly improved compared to usual treatment, along with other things that we consider, of course, clinically meaningful, like reduced suicidal ideation, reduced aggression, less likely to be hospitalized. And so we really can only treat the people in these early intervention programs who we've identified or who have been brought to our attention. So that's why we really need justice stakeholders to help us identify young people with those early warning signs of psychosis so we can get them to this more effective treatment. If people are interested in the details of these studies, there's a great review by Christopher Carell in 2017 going over all the evidence so far for these specialty programs. And so I mentioned coordinated specialty care. In some ways, you could think of coordinated specialty care as just very high quality behavioral health care. There are some unique aspects, such as an emphasis on and time for coordination, so really putting that first C in coordinated specialty care. So often there's scheduled time for teams to think about their shared treatment of that client, to reach out to other people who are involved, such as schools, and we'll also talk, of course, about justice system stakeholders, but really not seeing treatment as just about kind of coming in for medication and counseling, but how can we help the young person navigate multiple systems and make sure they're getting all of these needs met in a very holistic way. There's also another distinction, which is the assertive outreach piece. So these programs don't tend to only treat people who show up eager to engage in care. We're often making sure we work really hard to get people in the door or even go out to them, and there's a big emphasis on engagement. So it's not uncommon for people to not want treatment in the first episode. They don't necessarily believe they have an illness, but good coordinated specialty care programs will find a way to creatively engage that person around some kind of goal that the young person has. We really emphasize education and employment. It's not just about symptom reduction, and we really focus on how can we prevent future episodes of psychosis and help this person function at the highest capacity that they can. We also make sure that we're iteratively assessing symptoms. So there can be a lot of diagnostic ambiguity. Something that starts out looking one way from a diagnosis standpoint over time might look different, as is the kind of typical of the first few years of illness onset. So we do repeated assessment. We're really interested in safety and reducing risk. Families are involved. That's a key component of coordinated specialty care. And also things like using the least amount of medication possible to get good effects. So we don't want to over-medicate people. We're not interested in obliterating symptoms. We're interested in finding just that right balance so that the person gets relief but can still function and have less likelihood of side effects or feel negatively about medication because of being over-medicated. And a really important component of these programs that we would want to also have conveyed with justice stakeholders who are going to interact with these clients is an optimism about recovery, and that really we're emphasizing the person getting back on track and returning to as close as possible to where they were before all this started, or getting back on their trajectory. There's good reason to think that that can happen. We're not just kind of being Pollyanna-ish about it. And historically, there's been a lot of pessimism about psychotic disorders, and I think that's unduly influenced people's outcomes and their willingness to think of themselves as in need of this kind of care. So it's not uncommon if people have been to treatment programs prior to ours that they might hear, you know, you've got to go on disability, or your lot in life is to be in and out of the hospital, and that just simply does not have to be the case, and is certainly not how we would describe the person's likely trajectory. So that optimism is really important. So how can we work together between these specialty programs and the justice system? And this can go in both directions. The slide is a little bit worded more towards CSC clinicians, but it can go certainly in the other direction of justice stakeholders reaching out to CSC programs. So as they would be with other systems like colleges and universities or primary care, we want CSC clinicians to be proactive and get involved when their clients are involved in the justice system. So it's, again, part of that coordination. And not just when we have individual clients who need some coordination around their justice involvement, but also building those relationships in the community with the justice stakeholders. So whether it's local law enforcement or the people who do screenings in lockup when people have become incarcerated, or if you have a jail diversion program in your community, all probation officers, all of those are really important relationships, both for when you have clients who need coordination, but also those roles can be engaged in early detection. And so these are things that, just like other aspects of care, we can engage in problem solving with our clients. We can help them access resources and provide education about the process. So all that really great information that Leah provided, if we're knowledgeable about how the justice system works and can help our clients understand that better, just like any other kind of education, that can reduce anxiety and provide reassurance to our clients. And accessing resources, sometimes we find when clients come to us, they already have legal involvement, and they weren't necessarily aware of or referred to things that could be helpful to them, whether it's some kind of legal aid or a formal jail diversion program that they might be eligible for. So it's really important to know what's available in your community. And we can work together, CSCs and pretrial services, jail diversion. We're fortunate in our setting to have a liaison between our mental health center and our CIT officers. So we have a lot of different ways that we interact with the justice system. And sometimes with these specialty courts, if someone is arrested and charged, those are other ways that we can participate in that aspect of a client's life. And on the other direction, we want criminal justice stakeholders to know what their local resources are for specialty care. So there's a number of places this information can be found that are at the end of these slides, but there are now directories and places where you can go to find out what's the nearest CSC to you, or what's available in your community. And I would bet that any true CSC program would be happy to hear from justice stakeholders who reach out and say, how do I make a referral, or I have this young person that I keep coming into contact with, or that's currently in lockup, and I think that they're experiencing psychosis. Can you screen them, or can you help me out with this? So there are certainly a number of ways that the justice system can refer at some of those intercepts to CSC. All right. So speaking of referrals, so we have these directories where you can find where your CSC is. And as part of that process, it's important to engage with the young person in a way that they'll be more likely to respond to. So we want clients to feel heard and understood, so we make sure that when they're speaking about their experiences, even if they sound very bizarre to us, even if they're clearly not reality-based, everybody wants to feel heard, and we can certainly normalize the experience or validate the experience without getting focused on the content. So for example, we could say something like, that sounds really frightening. We're not necessarily saying, well, that really happened to you, and we certainly aren't getting into a power struggle with them about what's real and not real. That's a really unhelpful thing to do when a person does not have awareness that what they're experiencing is an illness. So try to avoid those power struggles. It's helpful if you can even ask permission before offering your perspective. So hearing the person out and then saying something like, using their own language if you can, but saying, these things that are happening to you, they can happen to a lot of young people, that sometimes people see and hear things and aren't there, or their thoughts become really jumbled up, and there's a program that can really help you with that kind of thing. So being attentive to how your body language is coming across, so you don't want to appear standoffish or stressed out or that you're freaked out by these things that you're hearing. So trying to appear relaxed as much as possible and remain poised, even if the person is saying something really bizarre or concerning, because a lot of young people will pick up on that if you are if you're being reactive to what they're saying. A lot of people in the first episode of Psychosis retain some level of awareness. They may know or be aware of the fact that what they're saying can sound bizarre to other people, so we really don't want to cause them to kind of clam up and not want to talk about it, because nobody wants to be judged. It's very common for the young people we work with to be worried about being seen as, quote, crazy. So it's important that we don't react to them in those kinds of ways that we can convey. This is something that we see a lot. It's really common for young people to have these concerns or struggles, and convey optimism. Again, you could say people who go to these kinds of programs really get their lives back on track. I'm sure they'll be able to help you. And most importantly, we do not take a wait-and-see approach. The most effective strategy that you can engage in terms of improving outcomes is reducing that duration of untreated psychosis. So if you see something, say something. If you think you might be observing psychosis, the coordinated specialty care programs or other providers who are familiar with psychosis will be happy to sort it out. It's not something you have to kind of wait until it becomes obvious. So no harm if the person's referred and it turns out they don't have psychosis, but a lot of harm can happen if there's a delay in accessing care. And there's concern that can be expressed particularly among the coordinated specialty care programs, about how can we follow our values or our principles as a program and work with people who are in a criminal justice setting, or are those principles even possible to be followed in criminal justice settings? So I think the answer to that is yes, they can be, and a lot of that can be accomplished by being familiar with the elements of procedural justice. So it's not necessarily that we can always affect the legal outcome, but we can make sure that people feel heard, that they are given a chance to tell their story, they're treated respectfully and with dignity, that as much as possible they can be involved in the decision-making process, so giving them options when there are options, that the process is transparent and seen as fair, and that we avoid overt, coercive kinds of behaviors. So there's good research on this, that engaging in that procedural justice can reduce the likelihood that the person feels coerced or feels negatively about their experience, even if it's in an involuntary setting like mandated treatment. So those are things I think we would pride ourselves on doing anyway in CSC, and there's no reason why we can't apply those same things when someone has justice involvement or that justice stakeholders can't engage in procedural justice principles. Often as providers and as justice stakeholders, it's important that we clarify what is our role, what is our relationship with that client, what are the boundaries and limits to those boundaries, and if there's any conditions for their treatment. And that because of some of the cognitive challenges and all these things being stressful, it's important that we reiterate that or repeat that as often as necessary. So, for example, when we're working with either jail diversion or someone who's on probation or community monitoring, in our program, we describe things as, our role is the treatment provider. We're happy to provide you with support and treatment around your goals. You entered into this relationship with the judge, or you and the judge have this agreement that you're going to follow treatment recommendations in order to hopefully have your charges dropped. So we'll help you meet that agreement that you have with the judge. And then we talk about, what are the things that we will or won't talk about, what information is being shared, and we do set boundaries because it's not the case that just because somebody has justice involvement that they have zero confidentiality. And that's important to educate yourself on what are their rights and laws regarding confidentiality. Sometimes people can hear that it's a lawyer or a police officer or somebody from the judicial system and think, well, then I have to turn over this information. But that's not the case, and certainly important that if you're getting requests to share information without a release that was obtained voluntarily, that you seek supervision or consultation from your treatment setting whenever you're not sure. So we often will give summary information in our program, not necessarily the full, intimate details of counseling. So just a couple of quick case presentations before we open it up to Q&A to hopefully make some of this kind of come to life from some composite examples from the STEP program of things that we've experienced with clients. So the first example would be Terrence. So Terrence was experiencing paranoid delusions. He thought that people in his community were out to get him, that they wanted to harm him. He believed that they thought he had done something wrong. And so he started getting in arguments with people on the sidewalk. He would accost people verbally in the community. This resulted in multiple times that the police were called. And thankfully, these police officers decided to bring Terrence to the emergency department so that they recognized he was mentally ill and needed treatment. But unfortunately, there were some charges that were brought. So he was referred to his local CSC program, and also had to appear at arraignment where he was offered community monitoring through the local jail diversion program. So there might be times when that actually could get missed. So if the client was referred to us with legal charges, we would make sure that they had the opportunity to speak with jail diversion staff or to get access to those kinds of programs. So something I forgot to mention earlier, but it can go in both directions. Jail diversion might bring somebody to your attention as a CSE provider, or as a CSE provider, you might say, call up your jail diversion program and find out if it's possible for the person's charges to be dismissed with treatment, or for them to get treatment instead of going forward with trial or incarceration. So in this case, the CSE clinician engaged Terrence, really made it clear to him that CSE was an option, so that he made this agreement with the court that he was going to participate in some kind of treatment, and CSE was just one of those choices. So that's one of those elements of procedural justice, being given a choice. She clarified to Terrence that her job was to really support him in meeting his identified goals, which were to get a job and to rebuild some friendships, but also that she wanted to make sure he could fulfill his agreement with the court, so that she would help him in making sure that he was keeping the court happy. They discussed in detail what information would and would not be shared. And then the jail diversion staff and the CSE clinician collaborated together, particularly around things like how and what to communicate with the judge. So we don't want to say things like, well, Terrence missed a few appointments, so he's out of compliance, because those of us who work with first episode psychosis and young people in general know that engagement can be a challenge. It's not uncommon for them to miss appointments. So we're certainly not looking to find every way possible to penalize somebody. So we're going to really think about what language we want to use and how we can communicate with the judicial system. So otherwise, we worked with Terrence just like any other client, and the justice involvement was just one element of coordination that we were involved in. And then Nancy is a young woman who she was following some delusional beliefs she had about thinking that she was being given messages and that she needed to follow these instructions. And ultimately, that put her on some private property and resulted in a trespassing charge for which she was given probation. So when we met her, she was on probation and gave us permission to reach out to her probation officer so that we could get more information about what were the terms of Nancy's probation so we could help her make sure she didn't violate those. Not because we're enforcers of probation, but because we want to make sure Nancy has the best possible chance of not violating her probation and ultimately ending up in jail. And we also took that as an opportunity to educate the probation officer on what is first episode psychosis so that the probation officer could understand what might be some challenges that Nancy would have and how could the probation officer adjust how they were delivering information to or giving instructions to Nancy, and we worked together on that. And then we worked with a probation officer to develop more feasible plans. So there are terms of her probation, things that she needed to do, but we were able to break that down in different ways and figure out what might be possible for her to accomplish. And we found that lots of probation officers, most probation officers, aren't necessarily looking for ways to violate our clients. They're trying to figure out what are reasonable ways that these requirements can be met. So most probation officers are willing to work with us. And sorry, I missed a typo there that should say probation rather than parole. And later we'll go back to talking about resources that you'll be given when these slides come out to you. But for now, I'll just say thank you for your time and attention and turn it back over to the Gaines Center to moderate Q&A.
Thank you so much. All right, so this time we'll start into our Q&A, but first, if we could just back up a couple of slides and if either one of you could just explain each of the resources there so that when we do make it available for download, people know what they're accessing here.
Sure. Yes.
I can do that if you want, Jessica.
Oh, yeah, I just wasn't sure if I was on speaker or not. Yeah, go ahead.
Sure. So we have a couple of resources up here for all of you that you can access after the presentation. The first one is a document that David Shern mentioned in the beginning, developed by the National Association of State Mental Health Program Directors. And it's really a guide that covers a lot of the material we talked about here, thinking about how criminal justice stakeholders can be involved in early detection. The second article here is an article that's written by Jessica and her team in thinking about using that very same sequential intercept model to highlight the opportunities to identify people with first episode psychosis. And then the final things are treatment locators that people can click on to locate service programs in their area, coordinated specialty care programs in their area, and as well as a final resource from the Massachusetts Psychosis Network for Early Treatment, which is a website that has multiple resources as well.
And I would just add a couple of things to that, which is the first link will bring you to the overall NASHBID Early Psychosis Virtual Resource Center, which has the paper that Leah mentioned, but also other issue briefs, webinars, trainings, and if you're a justice stakeholder and you would like to know more about psychosis, there are presentations and trainings that are geared toward people who are unfamiliar with psychosis and want to really understand what to look for, as well as some papers around early detection and how to do kind of community-based educational campaigns. And really importantly, I somehow it got cut off. Actually, the first author on that paper is Tobias Wasser, so I want to acknowledge that somehow he got chopped off from that citation. So that should be Wasser, Pollard, Fisk, and Srihari. So apologies to Tobias if he's listening. He certainly should have authorship on that. And then previously people had specifically asked about veterans and their involvement. So the MapNet End resource has a lot of different trainings, but specifically one on veterans.
All right, wonderful. Thank you so much. Many of you have seen now a file transfer box pop up on your screen. And so what you can do is click on underneath the line that says file name, click on additional resource, and then the download button will then turn a darker shade of gray, and then you should be able to click download, and this document with the active hyperlinks will download to your website, so you can then access the links that are provided in this resource. So we'll leave that up for a few minutes so you all can download that, and we'll transition now to looking at some questions that have come in. We've had a number of great questions come in. The first question I'd like to ask can go for both of you. Are you aware of any other trainings / certifications that criminal justice stakeholders can receive for correctly identifying and referring individuals with psychosis?
Yeah, I think some of the ones that NASHBID has on its website are really good in terms of going into detail about what psychosis looks like. One of them is specifically a training course. It's geared toward families, but would also be, I think, helpful to justice stakeholders. I don't know if there are any specific to justice stakeholders, like designed for their particular training needs. That's something Leah and I are working on for another project, but maybe you have anything to add to that, Leah?
I would just say, kind of zooming out, in addition to specific resources that Jessica mentioned around first episode psychosis, there are kind of broader training programs available. Crisis intervention team training that's offered through a number of organizations, such as Crisis Intervention Team International, offers kind of a more holistic view at mental illnesses and how police officers might encounter them, or corrections officers for that matter. That's a 40-hour training that many agencies are taking advantage of. And mental health first aid training is another training. That's an 8-hour training. I think both of those trainings are really geared more broadly around symptoms, interacting with people with symptoms of mental illness. And really, I think Jessica and I would both agree, I don't think we're asking criminal justice stakeholders to be able to diagnose in any situation, but to just notice the symptoms and then refer people to appropriate care so that they can make the diagnosis. So I think really thinking about trainings that can elevate those, being able to notice the symptoms and then interact with people appropriately to make warm handoffs to service providers.
All right, thank you. We've had a couple of questions come in about specific behaviors, so we'll cover those. The first one was, can you address the observation that self-report by incarcerated individuals about their past or current distress might be especially prone to exaggeration? So how would you respond to that? That's for both you and Leah and Jessica.
I'm sorry, could you repeat that question?
Sure.
Or paraphrase?
Sure. The question is, can you address the observation that self-report by incarcerated individuals about their past or current distress might be especially prone to exaggeration?
So yeah, there certainly can be reasons why people might be motivated to provide or to get to be diagnosed or to be getting treatment, or what people would refer to as malingering or secondary gain. I would just say, I mean, I'm coming from the treatment standpoint, so I have that bias, but I would rather err on the side of taking those, at least initially, at face value, and erring on the side of inclusion or providing treatment. Certainly not, we're not doing forensic evaluations in these kinds of programs where we're determining whether or not there's malingering or whether or not the person's symptoms were directly related to their crime. But I would say the risk of not treating is greater than the risk of treating something that might be exaggerated or malingered. So I don't think that we have any compelling way to distinguish that currently as broadly, to say, you know, it's X percentage or there's this particular thing. There certainly are malingering scales that people may be familiar with, but just from a sort of a first episode treater perspective, I would say that I would rather take that risk that the person may be overblowing their symptoms, because as I said in the kind of the middle of the presentation, we do assess things over time, and we take into consideration how symptoms present as time goes on. And we sometimes do determine that, well, this really isn't a primary psychotic disorder, it's something else, maybe a personality disorder, or the person had motivation to present with a particular diagnosis. But I'm not sure if that addresses the question, or Leah, if you would put it differently.
I think you put it very well. I think I would just potentially add two things. One is that, for as many anecdotes as we hear about people maybe exaggerating their symptoms, we also know that there are very good reasons why people might minimize their symptoms in jail or prison environments in order to avoid being noticed or being a target of other people. So we know that to be the case. And then I would also just add that, kind of in line with Jessica's point about, risking being like overly sensitive to symptoms and catching people, that having just finished a project working with a number of jails across the country around suicide and self-harm prevention, I think, erring on the side of caution and treating all symptoms as equally serious is really an important thing to think about in terms of self-harm and suicide prevention, which continues to be the leading cause of death in jails and prisons.
The stigma point you made is really good, Leah, because I think we do see, especially with younger people, a reluctance often to disclose these symptoms for fear of judgment and in fact, realistic concerns about discrimination they may experience as somebody who has psychosis. So I think we want to be much more thinking about, is somebody minimizing or are they reluctant to disclose? We've had lots and lots of people referred to us who had seen multiple providers and who had interacted with lots of people who had the opportunity to intervene, but they didn't feel comfortable disclosing to that person because, as I mentioned before, it can be, the person can be sensitive to, how's this person going to react? Are they starting to look at me funny when I start to talk about my ideas? And shut down pretty quickly.
Mm-hmm.
Thanks so much. The second question was around psychosis that's induced by substance use, particularly during withdrawal episodes. Would you have any specific recommendations to address those types of needs when psychosis may result from substance use withdrawal?
Well, I would say we, similarly to the prior question, we err on the side of inclusion in terms of if we're not sure if what we're seeing is primary psychosis or primary substance use, we go ahead and include them as somebody who needs treatment for psychosis. I wouldn't feel qualified to talk about if the question is really how to effectively medically intervene around withdrawal from substances. That's not something I could answer as a psychologist with any qualifications. But we do have that as a thought. Even cannabis withdrawal, we can see psychosis. But we also know that substance-induced psychosis can, over time, turn into a chronic psychotic disorder. So people who initially present looking like they have a substance-induced psychosis have a much higher likelihood of later qualifying for a diagnosis of chronic schizophrenia or other psychotic disorders. So we certainly don't want to prematurely exclude people like that, and we do want to actively treat their psychosis regardless, even if we need to treat it alongside substance use.
Thank you. Leah, do you have any other comments to add to that?
No, I don't think I have anything to add to that.
Okay. All right, I've had a couple of people mention the study of specialty care data, and they were asking more information about that particular study, if there might be a reference or authors' names associated that they could search to find more information about it.
About the effectiveness of early intervention, or the justice study in particular?
The person described it as the 2017 study of specialty care data.
Yeah, thank you for clarifying. So Christopher Carell is the author who did a review in 2017, and it's in JAMA Psychiatry, I'm almost certain. And he reviews basically all of the clinical trials and all of the evidence base for early intervention for first episode psychosis. So it's a great overview of the state of that literature so far. I actually have the reference here. So, it's Christopher Carell in JAMA Psychiatry, and a comparison of early intervention services versus treatment as usual for early phase psychosis, a systematic review, meta-analysis, and meta-regression.
Thank you.
Oh, although I have it as 2018. Okay, I'm going to double check that.
Okay. All right, thank you. Sure. We've had a couple of questions emerge about Medicaid and IMD exclusion. One person asked if you think that IMD exclusion should be ended. Another person asking for, what you all think in terms of the role of Medicaid, particularly specifically referencing the IMD exclusions. So would either of you have a comment in response to those types of questions?
So I think if I understand the question correctly, in this case, we're really thinking about the Medicaid exclusion for charging for jails and prisons to be covering behavioral health services. So if that's really what the question's about, I think this is a very complicated issue, and I've seen a lot of arguments on both sides coming from good places. I mean, I think my personal stance is that, to the extent that people are being sent to jail and prison in this country, that they should have access to evidence-based care, and that jails and prisons really have a patchwork of medical provision that aren't always up to the evidence-based standards, because there are really a lack of requirements and standards for these institutions. And so one way to think about improving standards is to think about, were Medicaid services able to be billed? Could you also, build in a better kind of standard of care, and have obviously access to more funding to provide that care? At the same time, I think there are very legitimate concerns that once you open up Medicaid funding to jails and prisons, that becomes a reason potentially for people to get sent to jail and prison to receive treatment that they really should be receiving in the community. And so there are, people who rightly argue that we really can't talk about removing that exclusion unless we talk about how we're building up community service capacity, because certainly we don't want jail to become any more of a default health provider for people. So I think it's a complicated issue overall.
The only thing I would add to that is just, I think it would be for people who are incarcerated that being able to get those, to get Medicaid reinstated or active prior to discharge or prior to leaving as part of reentry programming and connecting people to having in-reach from these programs that can be covered by Medicaid into jails and prisons would be particularly effective. And I know some states are working on or have implemented reinstatement of benefits prior to actually leaving so that there's no gap in services and so that programs can start to engage without any delay. And even, as we would do for inpatient units, visiting somebody before they come out so that we can hopefully prevent them from falling through the cracks.
Okay, great. Thank you. I've had a couple of questions come up, and this is something we hear from the field all the time. How do we get around HIPAA when sharing information? And so I just wondered if either of you have any thoughts or pointers around, how to better share data and information between criminal justice and behavioral health treatment agencies.
Well, I don't know that we necessarily need to get around it, but, certainly to work with it effectively. So some of the things I mentioned, we really try to encourage our clients to have us be able to help coordinate their care, or not their care necessarily, but this aspect of their life. So we do pretty successfully get releases for probation officers, for attorneys. Not always. Certainly people can refuse that, and that can be frustrating, especially if you don't understand what's happening and the person's not able to convey it, and you think they may have some misunderstanding about what's going on with their charges. But we're fortunate in our system in that our jail diversion staff are part of our mental health center, so we don't. They're employees of our same agency, so we don't necessarily need a release for them. But yeah, I think sometimes there are creative ways if you're thinking really of workarounds. We've even had people who've been on GPS monitoring, and the probation officer or community monitoring person was able to see that they were in the inpatient facility and then realize, I need to track down the treatment providers, and then on their end they were able to let the person know it was a stipulation that they had to have open lines of communication. But yeah, I would just say that similarly to how we have reluctance from clients about talking to family members, we can see that same thing about the justice system, and we just try to make it clear to the person. Doesn't mean we have to have no restrictions on what we discuss. It can mean that we can actually help you reduce your stress by, by helping you understand this and by helping advocate for you.
Leah, do you have anything to add to that?
No, I think Jessica covered that very well. Thanks.
Okay, great. All right, so we've come to the end of our time for questions. If you do want more information, we will be sending out the slides, and make sure you sign up for the Gains listserv if you have not yet done so. This is where the slides will be sent out. We'll also attach to that email the document with the hyperlinks to the various resources. We noted that a few of you had trouble downloading that document, so we will send that out with the slides. And also, Jessica and Leah, we may follow up with you to get some more of those references of other studies that you mentioned during your presentation. It looks like there was interest in having those references. So we'll add that to the resource document. And please sign up for the Gains listserv. There's a link on your screen right now if you would like to go directly to our website to sign up. And also, if you want to reach out directly to us We are a TA center funded by SAMHSA, but if you want to directly reach out to us at the Gaines Center, we are available to provide phone-based consultation and help you work through questions you may have around these issues. Our website is listed here as well as our phone number, and so we welcome anyone who wants to reach out to us and get some phone-based consultation. We're happy to do that. So thank you so much for joining us today. We do have another webinar this week coming up on the 20th. We will be presenting again at 2 o'clock, and this webinar will be focused on the family drug treatment courts, if you're interested in learning more about those types of programs. And again, that will be June 20th at 2 o'clock sharp. Thanks so much for joining us, and have a great afternoon.